Good afternoon, everybody. My name is King Lam, and I'm a hematopathologist at Erasmus MC here in Rotterdam. I want to welcome you all to the part 7 of the webinar series on reactive and neoplastic lymphadenopathies. And this time it will be about Hodgkin's lymphoma on the request of many of you. This webinar is made possible by the financial and logistical support of Ricordati Rare Disease Group, and we are very grateful to them that they have provided us the means to do this webinar. And also we are grateful to the technical support of Smart in Media. And today we will address, as I said, one of the remaining requests on the survey, namely Hodgkin's lymphoma in all its diversity, I would say. May I have the second slide? Yeah, these are my disclosures. I have to leave them on for a second or 5 or so, I think. May I have then the third slide? Now here you see the multi-purpose slide. Those of you who have followed the previous webinars will notice that this is the same slide with the same question. And the previous webinars on EBV-related lymphadenopathies and T-cell lymphoma, I've also used this slide. It's a multi-purpose slide. And the reason for that is the protagonist cell you see in this slide, the big cell with prominent nucleoli and also known as a Hodgkin cell. Well, it has been debated by many for what is really a Hodgkin cell, and I think Professor Toussaint will go into that a little bit more. And fortunately, it's nowadays we don't go by the criteria of it's a Hodgkin cell when 2 experienced pathologists call a Hodgkin cell. These days we have many more techniques to establish our diagnosis than only morphology, and we will of course demonstrate in this webinar how to use them. So the program is quite simple. After this introduction, we will hand over the floor to Professor Toussaint, followed by a clinical part of Professor Dieriks, and finishing with, but certainly not the least, by Professor Tiemann on his, with a few rare and not so rare cases. As you have noticed, the title of Professor Tiemann's talk has been changed a little bit, and that's to suit the content of his cases more. That will suit the content of his cases better. So may I have the next slide? This is some housekeeping rules. The first is a disclaimer, as you all can read. But the second one is please submit your question online. We will see whether we will handle them after the talk, or if there are too many, we will handle them in the discussion part. And please fill out the survey, which will be sent to you directly after the webinar. And that will give us feedback for the next topics. So without further ado, I will introduce Professor Thomas Toussaint. He's professor of pathology at the Catholic University of Leuven with a strong, I dare say, very strong focus on hematopathology. And he serves in various roles in Belgian and European societies of pathology, especially dealing with teaching. He's a talented teacher, as we have seen in the previous seminars. He is also an EXCO member of the Board of European Society for Hematopathology and has many years of experience practicing hematopathology, but also teaching hematopathology to fellows, residents, and students. Thomas will give us an introduction on Hodgkin lymphoma, highlighting some important points to consider when diagnosing a Hodgkin lymphoma or a mimicker. Thomas, the space or the floor is yours.
Thank you, King. So good afternoon, everybody. It's my pleasure to be present again for the 7th webinar sponsored by Ricordati, for which we are very grateful. Today, I will talk about the classification and diagnostic approach of a very intriguing disease, Hodgkin's lymphoma. These are my disclosures. I used during my talk some abbreviations, but I will explain them. But it's for those who want to look at it later, they can go back to this slide. So my talk will be built up like this. So I will quickly say something about the classification or classifications of Hodgkin lymphoma that are currently in use. How I establish the diagnosis of Hodgkin lymphoma based on morphology and some biomarkers, and then go into detail into some entities that mimic Hodgkin lymphoma and illustrate this with some cases. As you will see after the talk, scanned slides will be made available for each of the cases, so you can go back to them, you can study them in detail, but I will mainly go over some interesting points so you can look into them later by yourself into detail. So regarding the classification, well, there's currently, as you know, two classifications in use. There's on the one hand the WHO classification, which has a 5th edition, and the ICC classification. The WHO 5th edition does not distinguish that much from the 4th revised edition from 2017, in which there was a distinction between Hodgkin lymphoma and non-Hodgkin lymphomas, where Hodgkin lymphoma was mainly, or 95% of Hodgkin lymphomas were part of the classic Hodgkin lymphoma with 4 subtypes: the nodular sclerosis, lymphocyte-rich, mixed cellularity, and lymphocyte-depleted. And then there's the smaller group of nodular lymphocyte-predominant Hodgkin lymphoma. And I just want to stress that in the ICC, this category has shifted from the Hodgkin category to the non-Hodgkin category and was renamed nodular lymphocyte-predominant B-cell lymphoma instead of nodular lymphocyte-predominant Hodgkin lymphoma, which is still used in the 5th edition of the WHO. So that's important to note. For the rest, in the classification of Hodgkin itself, there's not so much that has changed. There has been some interest mainly in the EBV, the role of EBV in Hodgkin lymphoma, which I will tackle a little bit. But the main is that nodular LP is no longer a Hodgkin category. So for the diagnosis of classic Hodgkin lymphoma, so for the rest of the talk, I will focus on classic Hodgkin lymphoma. We need the prototypic cell, which is called a Hodgkin-Reed-Sternberg cell. But what you must know is that it's not sufficient to have these cells present to make the diagnosis of Hodgkin lymphoma. So it's necessary, but it's not enough to have it. What do you need for the rest? So you need these cells, and these cells, they need to be outnumbered in an inflammatory tumor microenvironment. So meaning that if you look at the biopsy, the majority of the cells that you see will be non-neoplastic cells, will be inflammatory cells. They make part of what we call the tumor microenvironment, and the composition of this tumor microenvironment will define as several subtypes. But the neoplastic cells themselves, they can also have a different morphology. So here you see the typical Reed-Sternberg cell, so the binucleated cell with a large nucleolus. The nucleolus almost reaches the size of a lymphocyte that lies next to it. But the morphology can be different. So we can have Hodgkin cells, which are mononuclear cells with a large nucleolus, resembling very large immunoblasts. Cells can be mummified. Cells can be multinucleated, or, and that's often a retraction artifact, can be lacunar. So these are different presentations of the neoplastic cell. The environment can also be different. So there is the two most common subtypes are the nodular sclerosis and mixed cellularity. As the name says, the nodular sclerosis subtype causes a thickening of the capsule, large fibrotic bands that are formed, and they delineate nodules. And in the nodules, you will find a mixed inflammatory infiltrate with these Hodgkin-Reed-Sternberg cells. The mixed cellularity type, on the other hand, is a more diffuse disturbance of the architecture with a composition, a mixed composition of cells with eosinophils, with plasma cells, with histiocytes, and then some few of these Reed-Sternberg cells. There's two other subtypes, the lymphocyte-rich and the lymphocyte-depleted subtypes that are less common. I won't go into detail about the lymphocyte-depleted case, but I will show a case that is reminiscent of a lymphocyte-rich classical Hodgkin lymphoma. the differential diagnosis for each of the subtypes, some of them are mentioned here, and during the talk I will go into detail for some of them. So that's the starting point. What is now the typical immunophenotype of these Reed-Sternberg cells? Typically, they will express CD30 in a membranous pattern, a strong membranous pattern, often with a Golgi dot. So weak expression of CD30 is not enough. It should be a strong membranous expression pattern. CD15 is a marker that is very often used, but is not the most reliable one. So most HRS cells will be positive, but there's also, or in most of the cases, if you study them well, part of the HRS cells will not express CD15. And then it has been described that CD45 is negative in these cells, but I personally, I don't use it. And the main reason why I don't use it, as you can see here, is because the cells that are from the stromal microenvironment that are outnumbering these Reed-Sternberg cells, they are all positive. And so they will line these Reed-Sternberg cells. And so it looks as if they are positive, but in fact, they are negative. So that's a marker I don't use. What is interesting, it took a long time before it was clear what the origin of this cell was. It was long thought that it had a histiocytic origin because of the large amount of cytoplasm, and also because of the fact that no clear expression of B-cell program was determined. Because if you look at several B-cell markers outlined here, CD20, CD79A, BOB1, OCT2, they're all negative in these cells. The only marker that indicates that the cell has a B-cell origin is PAX5. And if you look, PAX5 will be expressed in a weaker pattern than the reactive B cells that lie next to it. So in fact, this is the only witness of the B cell program is the presence of weak PAX5. The reason for that is that, in fact, the Reed-Sternberg cell is a crippled terminal center B cell that is rescued from apoptosis and is not expressing any immunoglobulin. Over the years, several other markers have been published. I will go over some of them. FASCIN is one that I don't regularly use, but it's a very specific, a very sensitive marker. It stains very nicely the Reed-Sternberg cells, but the problem is that it's also present in macrophages, and many of the Hodgkin lymphomas have macrophages in their tumor microenvironment, blurring a bit the image. So it's not the best marker to use. GATA3 is an interesting marker because, in fact, it's a T cell transcription factor, so staining in a nuclear pattern in T cells. But the Hodgkin Reed-Sternberg cells, they stand out very strongly. So even in a stronger pattern than the T cells that are surrounding it. It's not in all Hodgkin lymphomas present, but in like about 80% of Hodgkin lymphomas, we see this pattern. And it's interesting to use because other mimickers of Hodgkin lymphoma will mostly be negative for GATA3. So GATA3 will be positive in the T cells surrounding it, but the atypical cells of interest will mainly be negative. On the other hand, as it's a T cell marker, it's also found in T cell lymphomas like ALCL or in a PTCL subgroup. So, of course, be aware of that. And then one marker that I personally really like is IMP3. IMP3 is a protein involved in the embryogenesis and is present in normal reactive germinal center B cells. So if there's some germinal centers present, there's always an internal control for you to use them. But if you have a Hodgkin lymphoma, these Reed-Sternberg cells, they really stand out. So there's very little background cells that will stain. So it's very sensitive for Reed-Sternberg cells. But on the other hand, it's not specific. So it's not specific for Hodgkin, but because also nodular LP cells or EBV positive large B-cell lymphomas will also stain. But it will be negative in reactive immunoblasts. So if you doubt if some intermediate size or larger immunoblasts are reactive or they could be Reed-Sternberg cells, or if you have small biopsies, core needle biopsies, or even cytology specimens, IMP3 in combination with the other markers, of course, can be a very useful one. I really like that one. Other markers recently published, CD200 is one we tried to establish. It stains, as you can see here, nicely the Reed-Sternberg cells, but there's also some background cell staining. So some T cells, some dendritic cells are staining. So I personally don't like that one. Also, it's not so useful in the differential, for example, between Hodgkin and the LBCL, because they also tend to stain. PDL1 is interesting to notice, not so much for the diagnosis, but for the part that Dan will go into, mainly for further line treatments, because nearly all Hodgkin lymphomas will overexpress PDL1. And the overexpression, as you can see here, will be in the Reed-Sternberg cells, but also in the numerous histiocytes that are present. And the reason for this PDL1 overexpression is because there's an amplification of the PDL1 locus or copy gain numbers in Reed-Sternberg cells. And that's why, of course, it can be used for PD-1 inhibitor treatments. And then the role of EBV is very intriguing in this disease. In general, about half of the Hodgkin lymphomas will be EBV related. It's much more in mixed cellularity than in nodular sclerosis subtype. And what is interesting to notice is that they will always be latency 2. This means that there will be expression of LMP1, but not of EBNA2. A second thing is that the expression or the presence of EBV will only be in the large atypical cells, so in the Reed-Sternberg cells, and should not be in a whole spectrum of cells. So that's important to notice when you have, for example, a differential with some more polymorphic EBV positive B-cell LPDs or a diffuse large B-cell lymphoma. So that's important to notice. I also want to tackle a few markers that are in general negative in Reed-Sternberg cells, and that's because it's of B-cell origin, T-cell antigens should be negative. There's some rare reports of T-cell marker expression in Hodgkin Reed-Sternberg cells, but most T-cell antigens should be negative, as should the cytotoxic markers be negative. So if these are positive, consider other diagnoses, like, for example, ALCL. And particularly if ALK is positive, ALK should not be expressed in Reed-Sternberg cells, of course. Other markers that are typically negative in HRS cells is also a marker that in my hands is a very useful one. It's MEF2B. MEF2B is a marker involved in the activity of BCL6 in germinal center B cells, not in T cells. And it's consistently negative in Reed-Sternberg cells, but it's positive, for example, in nodular LP, as is J-chain. J-chain, I think at this point, the antibody is not available or it's very hard to get. So it used to be a good antibody, but it's not so widely available anymore. And then we have OCT2. OCT2 is a B-cell transcription factor, which is a very useful one, because if you look here at the panel, there's very strong expression, for example, in nodular LP, in other B-cell markers, or in other B-cell lymphomas, but should be negative in Reed-Sternberg cells. However, and that's something that is under study, EBV positive Hodgkin lymphomas tend to have, often have some more OCT2 expression. So in that case, it's not the best discriminator, but in other instances, for example, to discriminate with nodular LP is a very useful staining. So what is the standard approach when considering Hodgkin lymphoma from the immunohistochemical pattern? These are the markers I tend to use. So no expression of CD20, CD3, weak PAX5, expression of CD30, and the majority CD15. I prefer to use IMP3 over MEM1. MEM1 is also consistently positive in Reed-Sternberg cells, but of course plasma cells do stain. Reactive immunoblasts will stain. So I prefer IMP3. And then for to detect EBV, you have the choice. You can either use IBER-ish or LMP1. In the case of Hodgkin lymphoma, they are of equal value. Of course, if you consider other EBV-related lymphoproliferations, it might be necessary to do both or to add EBNA2, for example. ALK can be advised, particularly in younger people, in which you expect that, or there is a differential with ALCL, for example. Molecular testing is not so helpful in the diagnosis, PCR in particular, because of the minority of the tumor cells. It's often polyclonal for IgH or Ig-kappa, and there are even some cases in which T-cell receptor gene rearrangement can be found to be clonal on a polyclonal background, so PCR is not helpful. And then we have some studies done, well, mainly these were NIPT tests in pregnant females, in which we found as a coincidental finding the presence of aberrations related to Hodgkin lymphoma, and so asymptomatic cases of Hodgkin were discovered in pregnant females. But of course, it's not a standardly used technique. But even if the cells are so scarce in the tissue, the molecular aberrations can be detected using cell-free DNA. So, as you can see, I provided several cases. I will only discuss a few of them. I provided 3 prototypic cases of Hodgkin lymphoma. Case 1 is a nodular sclerosis, case 2 is a mixed cellularity, and case 5 is one with bone marrow involvement, because bone marrow involvement is not it's not so infrequent in Hodgkin lymphoma, and we had some cases in which the diagnosis of Hodgkin was made on a bone marrow biopsy before even the lymph node manifestation was present. At this point, we don't do bone marrow trephines in the staging of Hodgkin lymphoma anymore, as our nuclear medicine specialists are very good in detecting bone marrow involvement using PET scan. So case 1, very quickly, is a very typical case. Is a young male with, as you can see here, mediastinal and cervical lymph node involvement, very prominent, and on the low power, because it is in fact already a low power diagnosis, nodular sclerotic involvement of these lymph nodules that are being formed centrally in the nodules. You have these large atypical cells with some lacunar aspect, some eosinophils in between. Here you see these larger atypical cells that are outnumbered by inflammatory cells, and the typical immunophenotype expressing CD30, membranous and a Golgi dot-like pattern, strong MAM1, but as you can see, the plasma cells are a bit blurring the image here. CD15 is present, but also note that the eosinophils that are present will often be positive in on CD15, and this was an EBV negative case. Looking at the B cell markers, you see weak PAX5 expression, strong PAX5 expression in the I now see that the pointer is not active, so strong expression in the smaller reactive B cells, but no expression of CD20, no expression of OCT2, no expression of CD79A. This is a classic case of nodular sclerosis Hodgkin. Case 2 is also a young male with a history of mononucleosis many years before, presenting with fever and night sweats and weight loss, with involvement of lymph nodes above and under the diaphragm with bone marrow involvement, as you can see on the PET scan. And what is an interesting feature here is that this lymph node that was provided was a very superficial one and was only partially involved. So another argument to always provide excisional biopsies and not restrict to core needle or fine needle aspirations. In this case, the image is different. You see a very mixed inflammatory image, lots of eosinophils, lots of histiocytes, and then you need to really look for the atypical cells that are not so numerous, but you can find them, mononuclear cells, multinuclear cells. And again, the same immunophenotype expressing CD30, expressing CD15, no CD20, weak PAX5. And in this case, and that's often the case in a mixed cellularity case, expression of EBV. So only these larger Reed-Sternberg-like cells express EBV. And I showed this slide to explain a bit also the microenvironment in these, particularly in the EBV positive cases. You see on the CD4, there's some T cells, of course, present, but the majority of the CD4 is in fact copying the image on the CD163, so showing that there are a majority of histiocytes present. These histiocytes express PD-L1, as you can see here. PD-L1 is also expressed in the tumor cells. And although PD-1 is always very rare in these cases, and this could be useful, for example, if you consider other diagnoses like the T-cell lymphomas we discussed last time. Here an image of the bone marrow involvement of this case. So you see already at low power that there's something going on in these areas here. Often these will be characterized by some fibrosis, lots of histiocytes, and then you really need to look for the atypical cells because they will probably or often not be in the section, so you probably need to do more sections to find them. They are often intermixed with some histiocytes, eosinophils, so the background that you can see in the lymph node as well. And then if you do the markers, you can find the atypical cells easily because normally in a bone marrow we don't have, for example, CD30 expression. Okay, so these are the prototypical cases. Now I will go into some useful or try to give you some useful clues how to distinguish conditions that mimic Hodgkin lymphoma. And I will split this up into three parts. First is the clinical presentation. So it's very important to look at the clinical presentation if you look or if you consider Hodgkin lymphoma. If, for example, because you must know that Hodgkin is a nodal disease, so you need presentation in lymph nodes. If, for example, this is only an extranodal localization, consider, for example, that this could be an EBV-driven DLBCL, or particularly if, for example, if you have a solitary ulcer on the mucosa or on the skin in a patient that is being treated with methotrexate, for example, you can see nice cells that resemble Reed-Sternberg cells, but are, of course, Hodgkin Reed-Sternberg-like cells. They can express CD30, they can express IMP3, they express EBV, of course, but know that if you don't have any nodal involvement, that the diagnosis of Hodgkin is to be questioned. Other considerations are, of course, looking at the morphology of the cells. I already showed you the spectrum going to from the typical Reed-Sternberg cell over the mononuclear cell, the lacunar cell, etc. But of course, there's other lymphomas that have large atypical cells, like, for example, ALCL with the typical hallmark or donut cells as illustrated here. Look for them. Also, intrasinusoidal spread is something you normally don't see in Hodgkin lymphoma, but often is being seen in anaplastic large cell lymphoma. Cohesive sheet-like outgrowth, apart from the lymphocyte depleted Hodgkin lymphomas where you can see it. It's a very common feature of ALCL if it's of T-cell origin. And if you see large CD30 positive cells with a sheet-like pattern, but in a patient with a mediastinal involvement, rather consider primary mediastinal B-cell lymphoma or mediastinal gray zone lymphoma, or look for features that could point in towards that direction. And then, particularly in the EBV positive cases, one feature that is important to look at, particularly on the EBER, because on the LMP1 it's often not visible. You'll have to look at the EBER, that the size and variability in a classic Hodgkin lymphoma is very little. So it should be in the majority should be in the large atypical cells and not in a spectrum, as you can see here. Here you can see large cells, mainly intermediate sized cells, even some smaller cells. If you see a pattern like this, it's rather an EBV positive LPD rather than an EBV positive Hodgkin lymphoma. Regarding the immunophenotype, I explained you the typical immunophenotype, and now I will go into three cases with an unusual immunophenotype of the atypical cells. And The first two will be cases that have a B-cell program that is quite extensive. I told you normally there's only weak PAX5. Other B-cell markers are typically negative, or at least not present, as the guidelines say in the majority, so in more than 50% of the cells. I'll make a distinction between an EBV negative and an EBV positive case. And I will also discuss a case in which there is completely no B-cell program, but it mimics Hodgkin, that has no PAX5, no other B-cell markers, but has some T-cell markers and some cytotoxic markers. So these are three cases I will quickly discuss. And then, of course, one other thing is that if you are looking into EBV and you find expression of EBNA2, this means that the lymphoproliferation has a latency 3, and then you do not make a diagnosis of Hodgkin lymphoma, but then you need to look if this patient has some kind of known or unknown immune dysregulation. So these are cases I will discuss now. So the first one is a 62-year-old male, no medical history, presenting with a swelling in the neck, somewhat going up and down a little bit, but no other symptoms. And on the PET scan some multiple hypermetabolic lymphadenopathies in the cervical region. And this is the low power view where you see a vaguely nodular pattern. Also at intermediate power, you can see these vague nodules. Looking a bit deeper, you see that the background is mainly consisting of lymphocytes, no eosinophils, no plasma cells, and then you see these larger cells appearing. Some are mononuclear, some are binuclear, some are multinuclear. Here's some more details, a binuclear one, some other larger cells, but you see it's a very monotonous background of lymphocytes. Here you see a typical HRS cell, the Hodgkin-Rich-Sternberg cell. Here's some other examples, very large atypical cells surrounded by small lymphocytes that are not atypical. And this case was submitted with the question of lymphocytes rich classic Hodgkin lymphoma. This is the PAX5 with a very nice image showing these vague nodules that are somewhat moth-eaten. And in the moth-eaten pattern, you can see that the large atypical cells are present in the empty areas, and they are surrounded by by PAX5 negative cells. Same as seen in the CD20. So you see here cells that morphologically look very much like Rich-Sternberg cells, not like the typical vesicular LP cells of nodular LP, but they do express CD20. They are present partly in B cell areas, and they are partly in the interfollicular area, but they are mainly in these B cell areas. Other B cell markers, so PAX5, but also expression of OCT2, expression of CD20, as I showed, and also expression of CD79A. And you typically see, or here you can nicely see these binuclear cells, so looking very much like Rich-Sternberg cells. Looking at the CD30, it was, by the referring pathology, it was reported as positive, but looking at the slides, the atypical cells themselves, they are negative for CD30, and I think the CD30 positive cells are some reactive other immunoblasts that could be present. Same for CD15, no clear positivity. Also, MEM1 was mainly negative, and IMP3 was nicely positive. So it was submitted as classic Hodgkin lymphoma, mainly because of this IMP3 that has now been reported to be a sensitive marker for Hodgkin. And this is the T cell staining. So you can see lots of T cells present with expression of PD1 and expression of ICOS. So with a TFH phenotype, often rosetting or surrounding at least these atypical cells. And the nodules, they are supported by FDC networks. And then I think the diagnosis was made mainly because of the expression of the B cell pattern and of MEF2B. MEF2B, as you can see here, a very good, or a very nice marker illustrating the presence of these cells. And interestingly, this case was also IgD positive. And so that's, so we made a diagnosis of a nodular LP B-cell lymphoma, according to the ICC grade 1 and the IgD positive variant, which is a variant or a subtype that has been associated with an infection of Moraxella catarrhalis. In the WHO, this would be called nodular LP Hodgkin fan patterns A plus C. Second case, I will quickly go over because I want to focus on the third case, and I don't want to waste the other one's time. No, I will skip this case in the sake of time.
You have a little bit room, Thomas.
I have some room. Okay, but it's mainly because we saw several cases 2 webinars ago. So webinar 5, we saw a case. So this is a post-transplant patient with abdominal pain with lots of lymph nodes in the abdomen with a disturbed architecture and with an image that looked like this, with these large atypical cells, some clear binucleated Reed-Sternberg-like cells. And the background now is not only T or lymphocytes, it's mainly histiocytes and very epithelioid histiocytes. So as you can see here, very nice Reed-Sternberg cells. And this is the EBER, so it's an EBV driven lesion, and the background does not contain eosinophils, but mainly T cells and histiocytes. And the B cell program was very strong. So you can see they are CD20 positive, PAX5 positive, OCT2 positive, CD79A positive, also expressing CD30 and IMP3, no CD15 or MEF2B. And so this is a post-transplant PTLD, of course. And in the past, these cases, many of them were called Hodgkin-like PTLDs, but we try to avoid this name. And so this case was classified as a monomorphic, but with a T-cell histiocyte-rich like appearance. But this case is a very intriguing one. This is a 77-year-old female with massive adenopathies, also lesions in the bone. And this was the image. So it looks very much like a nodular sclerosis Hodgkin lymphoma. The only thing that is a bit unusual is these areas of necrosis that are present. But for the rest, at low power, you would expect this is a nodular sclerosis. Also at higher power, you see these nodules forming. And then cells in the nodules, you see some neutrophils, some eosinophils, these large atypical cells. And I think nobody would have problems making a diagnosis of a nodular sclerosis Hodgkin lymphoma based upon the morphology. CD30 nicely illustrating the cells, MUM1 pointing out the cells, but PAX5 did not stain, which is strange. It was a referral case, so I thought maybe it's a technical thing. Let's repeat it. Repeat PAX5, still negative. IMP3, very weak positivity, so a bit unusual because most of the cases of Hodgkin I see these days are very strongly and very uniformly positive for IMP3. And these cells seem to express CD2, TIA1, perforin, granzyme B. So no B cell markers, no ALK, no B or T cell receptor gene rearrangement, no rearrangement of ALK, DUSP22, TP63. And the question here is this a very rare case of a Hodgkin lymphoma with T cell markers? Or, and that's what I would prefer, that this is a diagnosis of ALCL mimicking Hodgkin lymphoma because of the fact of the T cell marker expression and the cytotoxic molecules. And then lastly, other clues to consider, other options than Hodgkin lymphoma. If there is no architectural effacement at all, you can, in nearly every reactive lymph node, you find CD30 positive cells, and they will be mainly B cells, but consider reactive lesions if there's no architectural effacement. If you see EBV positive lesions, and you think of you see Reed-Sternberg cells, but you also see this angiotropism, angiodestruction, the geographic type necrosis, rather consider it to be an EBV positive lymphoproliferations, also if there's numerous epithelioid histiocytes present. And that's a case, well, case 4 I already shown. If in the background of a Hodgkin lymphoma there are, or a case that you think that it's Hodgkin lymphoma, there are numerous B cells, consider a nodular LP Hodgkin lymphoma or a lymphocyte rich classical Hodgkin lymphoma. That's also possible, but there you have to look at the B cell program in the cells and look at MEF2B. And I saw that Professor Tiemann will illustrate a case, so I will not tell what it is. But also, if in the background there's numerous T cells, there's a few things you should look at. There you should look at the fact if the T cells are atypical or not. And if you go back to the previous webinar, webinar 6, there were some cases shown with numerous T cells with a high proliferation index. This is often a very good indicator, and a TFH phenotype with the presence of CD30 positive cells. They can be EBV positive, they can be EBV negative, but they are CD30 positive and they can look like Reed-Sternberg cells. But cases with angioimmunoblastic T cell lymphoma can have CD30 positive cells looking like Reed-Sternberg cells. So this in summary, many conditions that can look like Hodgkin lymphoma. There's non-specific lesions with CD30 positive immunoblasts. There's lots of viral-induced LPDs, mainly EBV related. And then there's B-cell lymphomas with cells that look like Reed-Sternberg cells. There's T-cell lymphomas with CD30 expression or with CD30 positive HRS-like cells. So know that the presence of HRS cells is not enough to make a diagnosis. You have to look both at the expression pattern and the morphology of the individual cells, and also look at the composition of the background in order to make your diagnosis. So what do I want you to remember from this talk is that Hodgkin is a nodal disease, very important, that it's not sufficient to have these Reed-Sternberg cells, but of course they are required, you need them. It's not enough to have some intermediate sized CD30 positive cells. You really need Hodgkin Reed-Sternberg morphology. Typical immunophenotype is CD30, weak PAX5, no other B cell markers, and EBV in half of the cases. IMP3, very useful marker, very sensitive, however, non-specific, and that you need to work up your case further in cases where you see unusual clinic, like no nodal involvement, unusual morphology, unusual immunophenotype, and so I illustrated these cases. And molecular tests are not useful. For people who are interested in some more details, I wrote a review in Virchow's archive last year explaining the evolution or summarizing the most recent findings in Hodgkin lymphoma. These are the case identifiers for those who want to look at the cases I submitted, and then some literature. And thank you very much for your attention, and I'm open to any questions at the end of the session. Thank you very much.
Okay, Thomas, thank you very, very much for your very comprehensive talk. Now we know why Hodgkin lymphoma is the most revised diagnosis of pathologists, one of the most, even hematopathologists. And indeed, we will go over the questions at the end of the session. But first, I will give now the floor to Professor Daan Dierickx. Professor Daan Dierickx is the head of the Laboratory of Experimental Hematology at the Catholic University of Leuven. And if you look at the website, you will see that his clinical and translational research contribution is quite large, especially in the area of PTLD and T-cell lymphomas, and mainly focused on genetic events aimed at providing and searching for therapeutic options. He is also involved in the teaching of medical students and residents with many contributions in this field. And he will teach us how to approach the patient with a mediastinal mass. And of course, what to do once the diagnosis has been established. Dan, the floor is yours.
Thank you very much to the organizers for giving me the opportunity to present our medical approach to mediastinal masses. These are my disclosures. So as I know the audience are mainly pathologists, I will try to give some basics on the mediastinum and mediastinal masses. Some basics on immune therapy, because we have a lot of new immune therapies in which we can use markers Thomas already discussed. And then I will give a short overview of the new immune therapies in mediastinal lymphomas. So first, the most important question for mediastinal lymphomas is, of course, what is the mediastinum? So maybe you all remember from the lessons of anatomy that the mediastinum is the space between both lungs or between both pleural cavities. And actually, it spreads from one pleural cavity. I will use my pointer. So from one pleural cavity to the other, and from above, from the thoracic outlet till the diaphragm, and then if you look at this point, from the sternum to the thoracic spine. And actually the mediastinum contains all intrathoracic structures, except of course for the lungs and the pleura. The radiologists, they know how important it is to divide the mediastinum in different compartments. And so there are different classifications, but this is the one that is mainly used. So you have actually 3 compartments in the mediastinum. You have the anterior, so the green one, or the prevascular space. You have the middle mediastinum, that's the red one, of the vascular space. And you have the posterior mediastinum of the postvascular space. So actually the base is the heart and the large arteries and veins who are in the middle mediastinum. So when we look at the middle mediastinum, you have the heart, you have all the different arteries, large veins. And of course, you see it also goes a little bit to the top. There you have the trachea, the oesophagus, and several lymph nodes. In the anterior mediastinum, you have the thymus, you have the lymph nodes, and then, of course, the last part, the posterior part, is the posterior mediastinum, which contains the thoracic spine and the paravertebral soft tissue. So, and based on this anatomical structure, we can already predict which malignancies or which tumors, it doesn't need to be a malignancy, but which tumors can be seen in which compartment of the mediastinum. So if you look at the anterior mediastinum, of course, the thymus is there, so thymoma or other thymic tumors can be identified there. You have germ cell neoplasms, and there are lymph nodes, so lymphoma is also an important part of the masses in the anterior mediastinum. In the middle mediastinum, you have the lymphoma, you have congenital cysts, and in the posterior mediastinum, of course, you have mostly the soft tissue, the neurogenic tumors, the sarcomas. And when we look both in adults and in pediatric population to the dissemination of the different tumors, and then you see that actually lymphoma is the most common mediastinal tumor. About 50% to 60% are lymphomas, followed by germ cell tumors, neurogenic tumors, and sarcomas. And here you see some examples. So the first 3 are anterior mediastinum masses. So here you see, for example, a thymoma, you see a thymic cyst, and here you see a more teratoma, so a germ cell neoplasm. This is a case, of course, we need a biopsy, but I can tell you it was a classical Hodgkin lymphoma, and here you see a ganglioneuroma. When we look or when we focus on mediastinal lymphomas, the most commonly encountered mediastinal lymphomas are acute lymphoblastic leukemia, but in that case, we call it lymphoblastic lymphoma. I will come back to that later. You have the primary mediastinal B-cell lymphoma, the mediastinal gray zone lymphoma, the nodular sclerosing classical Hodgkin lymphoma, and then the diffuse large B-cell lymphoma. The first 4 are most commonly seen in adolescents and in young adults, whereas the last one, the typical diffuse large B-cell lymphoma, is mainly seen in elderly age. How do mediastinal lymphomas present? Well, it really has a very heterogeneous way of presentation. So most important is often late because it can grow without any complaints or with atypical complaints. And then all of a sudden there is an urgency because the mediastinal lymphoma has grown so much that it compresses other structures. So it's often late. Initially, there are no symptoms. There can be a cough, dyspnea, stridor. It can present with a pleural or a pericardial effusion, and it also can present with compression of the vena cava superior, the so-called vena cava superior syndrome. And here you see examples of a mediastinal tumor, which shows the compression of the vena cava superior, leading to the typical symptoms of a vena cava superior syndrome. Here you see it really nice. So it's the drainage of the upper part of the body. So the other one, the lower part, is of course the vena cava inferior, but you have a compression on the vena cava superior. And the treatment we give for those patients is by asking our surgeon or our interventional radiologist to place a stent in the vena cava superior. And here you see the result. And actually, this gives a relief of the symptoms in a couple of hours. So that was the introduction on the mediastinum. Now I will go to some basic of immune therapy, because we all know immune therapy has really changed our therapeutic landscape in lymphomas. And actually, immune therapy can be divided into what we call passive immune therapy and active immune therapy. Passive means that something binds to the tumor and then in one or other way attracts the immune system or modulates the immune system. And typical examples are monoclonal antibodies and CAR-Ts. And then you also have the active immune system, where actually you give something that acts on the immune system itself. So there's no binding to the tumor, it acts on the immune system itself. And the typical example are the checkpoint inhibitors. So let's start with monoclonal antibodies. I think you all already heard about a lot of monoclonal antibodies, and you may have noticed that they actually have a strange name, for example, rituximab. So actually there is a real stem in the name. That's the MAP at the end. That's the monoclonal antibody. And then you have different other we call it substems. The first one is the source of the monoclonal antibody. So initially, all monoclonal antibodies were made from mice antibodies, and then the O is added, so ONAP or OMAP. Then it became partially humanized, so it was chimeric, that's the XmAb, or even more humanized, then it's ZUMAB, or it's fully human monoclonal antibodies, then it's UMAB. And another prefix is the TU or the LIM. TU means that's actually the target. So TU is tumor. So when you use it in oncology, it's called TU. So for example, TUXIMAB, or LIM stands for lymphocytes, and this means that it's mainly used in autoimmune disorders. So then you have, for example, Limumab, and then you have the first part, that's a prefix with no specific meaning, and which is actually unique for each medicine. So you have rituximab, you have adalimumab, and so you can actually see what's the origin of the monoclonal antibody. In hematology, we mainly use monoclonal antibodies against B cells. A typical side effect of monoclonal antibodies is because it's made from mouse or partially from mice. You see infusion-related reactions, so we give pre-medication to prevent those allergic reactions. And then, because you target B cells, you also see B cell aplasia necessitating immune globulin replacement in many patients. Important in monoclonal antibodies is that you find a good target antigen. So there are two really important considerations. So there needs to be a strong expression of the target antigen on the tumor, which leads to an efficacious therapy, but it only should be on the tumor because of safety reasons. And for this reason, CD19 and CD20 have become very popular because they are only expressed in partially on the B cells. So, for example, CD20, it doesn't target stem cells, it doesn't target plasma cells, so it doesn't give, for example, bone marrow aplasia when you treat a patient with anti-CD20. And another very important is CD30, as Thomas already discussed. It's seen on activated B and T cells, but it's very popular because it's expressed on almost all Hodgkin-Rich-Sternberg cells and also on several T-cell lymphomas. How can we use monoclonal antibodies? Well, we can use an unconjugated or a naked antibody. We can bind a chemotherapy on it, then it's called an antibody-drug conjugate. We can bind a radioisotope on it, then it's called radioimmunotherapy. I won't talk about that because it's logistically very difficult and we don't use it in the clinical practice. And then we can also combine actually two parts of antibodies, one against a target and one to attract T cells, and that's what we call the bispecific T cell engagers. So first, the unconjugated or the naked, for example, rituximab. So rituximab, you're aware that this is an anti-CD20 monoclonal antibody. It binds to CD20, and then it leads to antibody-dependent cell-mediated toxicity. So it attracts different effector cells of the immune system. It also leads to complement-dependent cytotoxicity. So it attracts the complement. It leads to direct apoptosis by internalization of the antibody, and it also leads to antibody-dependent phagocytosis using macrophages, which recognize the antibody and will also eat the tumor cell. Rituximab is the most well-known example, but you also have, for example, now tafasitamab, which is an engineered CD19 monoclonal antibody, which is now also used in the treatment of diffuse large B-cell lymphoma. You can conjugate the antibody with a chemotherapy, for example, brentuximab vedotin. So brentuximab is an anti-CD30 monoclonal antibody. You bind it with a chemotherapy. The monoclonal antibody binds to CD30 on the surface, and the whole complex is internalized, and there the chemotherapy is released and will kill the cell. So anti-CD13 is very well known, but also in diffuse large B-cell lymphoma, we also have now polatuzumab vedotin, which is an anti-CD79B monoclonal antibody with a chemotherapy. Most important side effect of this therapy is due to that chemotherapy, which can cause polyneuropathy, which is actually the most common observed side effect. Another example is another anti-CD19, loncastuximab tesirine, which is not reimbursed in Belgium yet, but will probably come in the future. And then we have the bispecific T-cell engagers, in which you have actually two parts of two different antibodies which are combined, one against a tumor cell, for example, anti-CD19, and one with targeting CD3 on cytotoxic T cells. And so when the antibody binds to the tumor, it attracts the T cells. Once again, we have different options now. In particular, CD20, I won't go into detail, but you have different bispecific T-cell engagers in the treatment of diffuse large B-cell lymphoma. They have a totally different side effect profile combined to chemotherapy. The two most important are cytokine release syndrome. So you have actually, you attract T cells and they will really release a lot of cytokines. One way to prevent this is step-up dosing. So you start with a very small dose of your bite, and then you gradually increase the dose. And another one is the neurotoxicity. Second are the checkpoint inhibitors. So Thomas already told about PD-1 and PD-L1. So you know if an T cell needs to be activated, you need actually 3 signals. The first signal is the binding of the T cell receptor to the HLA molecule with the antigen. That's the first signal. And then you have the co-stimulation. So the T cell needs co-stimulation to be activated. There is also a third signal, which is the cytokine release, but I won't talk about this now. So when a T cell wants to fight, for example, a virus, the first step will be that the CD28 on the T cell will bind to CD80 and CD86 on the antigen presenting cell, and this will activate the T cell. However, if, for example, if you have a virus, you don't want the immune system to be activated lifelong, so there will be an counter activation, so you will have expression of CTLA4 on the T cell, and CTLA4 will actually compete with or will bind also to CD80 and CD86 instead of CD28, and this will stop the immune response. Of course, in cancer, we want to go on with an immune response, and therefore we have now an anti-CTLA4 monoclonal antibody, which lead to continuous activation. So here you see it another way. You see first the binding of CD80 and CD86 to CD28. Then you have the upregulation of CTLA4, and the T cell is not activated anymore. And with the antibody, you can reactivate it. So it's a kind of switching on and off the immune system, actually like we often do with relationships. We want to turn it on, we want to turn it off, and so on. Another one is PD-1. So on antigen presenting cells, you have PD ligand 1 and 2. On the T cell, you have PD-1. PD-1 binds to PD-L1 and 2 and will, this is a negative co-stimulation, will not activate the T cells. When we give an anti-PD-1 monoclonal antibody, this will activate the immune system. And of course, here we also have side effects. As I already told, if you actually continue on activating your immune system will also, there's the risk that it will also attack your own body, and then you have autoimmune complications. So you see a lot of autoimmune complications with those checkpoint inhibitors of the gastrointestinal tract, the lungs, liver, skin, neuropathies, endocrinopathies, and so on. Another very important is in checkpoint inhibition is the pseudo progression. So if you give therapy, so this is a tumor, the gray cells are the tumor cells and the purple ones are the lymphocytes. If you treat a tumor with chemotherapy, that this is actually what you want. You want that all the cancer cells disappear. This is what you don't want, that the tumor is growing. But this is what you often see with checkpoint inhibition. So you see apparently a growing of a lymph nodes, and you think, oh no, the patient is progressing. But actually, it's an activation of the immune system, and you see a lymph node growing, but actually it's a responding lymph node. And that's how what we learned. We have to, or we had to reconsider our response evaluation. So in the beginning, we take some time, and patients can seemingly progress, but we know it's a kind of pseudo progression, and after a while, this will diminish. In hematology, just for practice reasons, we have actually only PD-1 inhibitors which are used, which are nivolumab and pembrolizumab. The last one is the CAR Ts. So CAR Ts are actually cells, T cells, which are taken away by apheresis by the patient. And then in the lab, a chimeric T cell is made. So you have your own T cell receptor, but you have a second T cell receptor, which is actually mimicking a T cell receptor. You have also the part which recognize an antigen, for example, CD19, and then you have co-stimulatory molecules, and then the CD3 zeta chain in the membrane. So you really mimic a T cell receptor, but really actually specific for one specific target. And then you give it back to the patients. It will go to the tumor. There it will bind to the tumor and it will kill the tumor. But on the same moment, it will also release cytokines and it will attract other T cells. And the most commonly used in lymphoma is CD19 CAR Ts. I won't go into the detail on the studies, but in diffuse large B-cell lymphoma, the first studies were in relapsed refractory patients, showing actually very promising results with a plateau. So this was the reason why CAR Ts were reimbursed first in relapsed patients. Then they went in the studies to second-line treatment, both in transplant-eligible and transplant-ineligible patients, showing, again, promising results. So now, at this point, CAR Ts are reimbursed for diffuse large B-cell lymphoma in second line in case a patient is refractory or relapse within a year after the first-line treatment. There's also one trial in first line. This is in very high-risk disease, double or triple hit lymphomas or large B-cell lymphomas with a very high prognostic score, with actually insufficient response after 2 cycles of chemoimmunotherapy. And then you see that these patients really have a poor prognosis. When you give them CAR Ts, actually their prognosis may be more promising, although I have to admit that the follow-up still is very short in this trial. And this is not reimbursed yet. Side effects are a little bit the same as in BiTEs. So you have cytokine release syndrome, and then you have the neurotoxicity, which is now called ICANS, the immune effector cell-associated neurotoxicity syndrome. Cytokine release typically occurs the first week after CAR Ts. The ICANS is most commonly between day 7 and day 12. These are really severe side effects, or can be very severe. So that's the reason why after CAR T administration, patients are kept in the hospital for 2 weeks. So let's get back now for the last part to our mediastinal lymphomas. So the first one was T-ALL or T lymphoblastic lymphoma. The distinction is actually based on the clinical presentation and the degree of bone marrow involvement. If there is a bone marrow is full of blasts, it's called a T-ALL. In other cases, if you have more nodal involvement, it's called a T lymphoblastic lymphoma. And we know in T lymphoblastic lymphoma that the mediastinum is involved in more than 70%. Probably you're aware that ALL necessitates a really very complex treatment strategy. You have induction, you have reinduction, you have consolidation, you often have maintenance. When we look at new immune therapies for T-ALL or T lymphoblastic lymphoma, it's actually disappointing. The only immune therapy we might have in the future is monoclonal antibodies against CD38, because blasts, both B lymphoblasts and T lymphoblasts, they actually express in the majority of cases CD38. But at this point, it's not reimbursed yet for ALL. Second one was primary mediastinal B-cell lymphoma, which has actually a very difficult differential diagnosis, sometimes with mediastinal gray zone lymphoma, nodular sclerosing Hodgkin lymphoma. So it's a kind of spectrum with the most difficult to treat the mediastinal gray zone lymphoma, which is not one type. So you have actually a whole spectrum. Some have the phenotype of classical Hodgkin lymphoma. Others have more the phenotype of primary mediastinal B-cell lymphoma. What do we have in primary mediastinal B-cell lymphoma? Well, of course, rituximab together with chemotherapy has become the standard of care, followed by radiotherapy if the PET scan is not negative. But CD20 really has changed the treatment landscape of all CD20 positive lymphomas, but also in primary mediastinal B-cell lymphoma. There are also some promising results in the relapsed refractory setting with CAR Ts. This is the progression-free survival, this overall survival of a study in which the primary mediastinal B-cell lymphomas could be included. There doesn't seem to be a difference whether you combine the CAR-Ts with checkpoint blockade or not. The most difficult one is the mediastinal gray zone lymphomas. So here you see the curves of the mediastinal versus the primary mediastinal B-cell lymphoma, seeing that the prognosis is very poor. And actually, we don't have any new immune therapy for mediastinal gray zone lymphoma. Of course, if they are CD20 positive, you can use rituximab. And then the Hodgkin lymphoma. So the mediastinal are mostly nodular sclerosing Hodgkin lymphoma, less the other subtypes. Treatment is actually based on the stage. So you have stage 1 or 2, which is typically treated with chemotherapy, followed by consolidation with involved node radiotherapy. And then you have the advanced stage, so the stage 3 or 4, which is typically treated with chemotherapy without radiotherapy. However, there are recently some very interesting treatments in first line. So first of all, there is brentuximab vedotin. So this study is a 5-year or 6-year in the meantime follow-up of the first line study in stage 3 or stage 4 classical Hodgkin lymphoma with brentuximab vedotin combined with chemotherapy. And there was at 6 years, there is finally a survival advantage. There was a progression-free survival advantage, but 6 years, there also seemed to be a survival advantage. And nowadays, brentuximab vedotin is reimbursed and is given in patients with classical Hodgkin lymphoma stage 4 diagnosis. And very recently, this new standard, the brentuximab plus chemotherapy, was compared with nivolumab, so with a checkpoint inhibitor, showing actually that it's, of course, a shorter follow-up, so we don't have data for overall survival, which typically takes many years in Hodgkin lymphoma because Hodgkin lymphoma itself has a good prognosis. And there you see that the progression-free survival was significantly better when you combine the chemotherapy with nivolumab compared to brentuximab, but this is not. This is recently published and is not reimbursed in Belgium. Thomas already told about rituximab. So at CD20, we know that about 20 to 30% of classical Hodgkin lymphoma show CD20 expression. There have been trials initially in refractory patients showing promising results with rituximab in classical Hodgkin lymphoma, but the randomized trials with rituximab, both in the limited stage as in the advanced stage, actually have shown no benefit. So we don't give at this point rituximab. Is it important to know the EBV status? We know that about 20 to 25% of the nodular sclerosing Hodgkin lymphomas are EBV associated. In contrast to, for example, lymphocyte depletion, which is almost 100% EBV association. At this point, it's not that important for us because we don't have really treatments specific for EBV positive, but it might be in the future when we give EBV-specific cytotoxic lymphocytes. The current treatments are targeting EBNA, which are not expressed in latency 2, as Thomas told. So we have to produce cytotoxic T lymphocytes against LMP1 or LMP2 to target EBV positive Hodgkin lymphoma. So this is still for the future. Voilà, this was the end. I tried to give a brief overview of mediastinal lymphomas and of the treatment, the new treatments for these patients. And I want to thank you for your attention.
Thank you very much, Dan, for your very comprehensive talk. I've certainly learned a lot to have to discuss it with my own clinicians. So There is a comment from Thomas, but we will reserve that for the discussion. Now I want to switch to Professor Marcus Tiemann, specialist in hematopathology at the Institute for Hematopathology in Hamburg. He is a founding partner and a managing director of this institute, and he also, while he has at it, established a few subsidiaries in molecular pathology in other German cities. He has an extensive experience in practicing and teaching hematopathology, of which numbers are years of experience is written in double digits. And he has a number of honorary professorship, and especially is an expert in Castleman's disease. Professor Tiemann will talk on Hodgkin lymphoma and non-Hodgkin mimickers. And I dare say idiopathic morbus Castleman might be one of the mimickers. Thomas, Marcus, the floor is yours. Excuse me.
Okay, thank you for these nice words, and I will be happy to do the final clean sweep of the stage. So we will go and analyze some cases, I think at least 4, and then find hopefully the solutions. So I will start with the presentation first. Okay, these are my disclosures. I will go to the first case, 64 years old man, and he has enlarged lymph nodes within the neck, right side of the neck, and there were suspicious to non-Hodgkin's lymphoma, the clinical colleague said, and additionally, he suffered from enlarged tonsils. The clinical symptoms were fever up to 38 degrees Celsius, and of course, these enlarged lymph nodes in multiple locations, weakness, thrombocytopenia, and lymphocytosis, granulocytosis, and monocytosis. Going into these slides, you see lymphocytosis, white blood cells, 32,000, thrombocytopenia, only 50,000 platelets, and then here monocytosis, lymphocytosis, and the neutrophils are also increased in number, and some increased basophils, but borderline. So what to do with the enlarged lymph node and the tonsils? The ENT colleagues extirpated these lymph nodes and the tonsils, and we will have a short glimpse at the histology now. So this is, of course, not normal lymph node tissue, and the architecture seems to be destroyed. Or this is also not normal tonsil tissue, and we should have a short look within other areas, like here. Mostly small cells, some intermingled larger cells, here or here, some smaller blasts. So not very conclusive. What to do? I think at least to do immunohistochemistry. So we should have at first look within CD20. This is CD20, and you see most of these cells are B cells. B cells all over the field. It's not unusual for tonsils, but we cannot find any germinal centers, or here, maybe here, this one, but they seem to overgrown by other cells. And then we should look to the lymph node.
Yeah.
Again, an overview. This could have been germinal centers, but diving into the higher magnification, you see mostly small lymphocytes and some intermingled eosinophils. No blasts. Again here, small cells, eosinophils, some vessels here. Not very conclusive. Then we will look in the lymph node, the I think CD20 first, should be this one, yes. And again, you see the same picture as within the tonsil, and pseudofollicular growth pattern, small cells, some vessels intermingled, and most of these cells are B cells. And then small B cells, you would like to see CD5, whether there is a co-expression, and you suppose could be co-expression. And indeed, you see strong stained small T lymphocytes and weak stained B cells here. Weak staining. And then I think CD23 should be also of interest. CD23. Here are some reminiscence of germinal centers, the networks of FDCs, but you see at least 60–70% of the B cells co-express CD23. So we have a co-expression of CD20, CD5, and CD23. Your first idea is CLL, of course, or small lymphocytic lymphoma. This seems to be clear. And again, here is a reminiscent follicle, a pre-existing follicle, and here these are pseudofollicles. This is not a follicular lymphoma, it's a nodular growth pattern. And CD23 and CD21 are very helpful to distinguish these both nodules from each other. Okay, and then we have just another point, CD30. And surprise, surprise, here are some CD30 cells included. Larger cells, sometimes binucleated, an example here, and some smaller than Hodgkin cells, but most, this is also a Reed-Sternberg cell with a large Golgi area, Golgi field filled up with CD30 antibody, CD30 antigen. Okay, so this is a different pattern and a combination. It seems to be a combination. So is this CLL with Hodgkin cells, or is it a combination of Hodgkin's and CLL, or how would you call this? Okay, and then we go back. Here again, CD10, the pre-existing germinal centers, and then the specific histology we have already seen, and here some larger Reed-Sternberg cells and the overview of the Hodgkin cells, and then the key 67, you see the proliferating germinal centers, the lower proliferation of the small lymphocytes, and the Hodgkin cells mostly positive. So in the end, the diagnosis was chronic lymphatic leukemia or small cell lymphocytic lymphoma. And then we had a discussion, what is a Richter syndrome? Indeed, the combination of Hodgkin cells without any changing of the histology with CLL is considered as Richter's transformation. I learned Richter's transformation to be a transformation within diffuse large B-cell lymphoma, but I think this is a good idea to put them together as Richter transformation. But this is a typical mimicker of Hodgkin or non-Hodgkin lymphoma. You first look for the small cells and then sometimes oversee the larger cells, or you first look to the larger cells and then oversee the smaller cells. So in the end, this is the diagnosis. And the next one is case 2, 62 years old man, and he has enlarged lymph nodes in the left groin, or one enlarged lymph node in the left groin, and this lymph node was taken out by the surgeons, and the question was malignancy. Clinical findings, as usual, fever, fatigue, night sweat, and he was hepatitis C positive. And the clinical anamnesis found out he was an IV drug abuser. Here, HAT first, of course, you're familiar with. You see this enlarged lymph node. Architecture seems to be preserved. Small follicles here, a little bit too small for the size of a lymph node. And follicle mantles widened. Number of blasts seems to be normal here. And increased vessels, high endothelial venules, increased numbers of high endothelial venules. And here, some eosinophils also intermingled here. But these plasma cells and high endothelial vessels, they are increased in number. And then we have to look for other germinal centers, whether they are normal or not. This is normal, monocytic B cells. This is normal. This is normal. And here, they are changed. The number of blasts are diminished. And we should first look what is the distribution of B cells. And let me see, CD20. Not so bad, but large B cell nodules here. Germinal centers, but not so many blasts, only here. Widened follicle mantles. And here some regressive changings. Seems that they seem to be destroyed or somehow changed. And some vessels coming from outside within these B cell areas. Okay, going out, taking the next slide. Next slide is CD21. You see many of these follicles, of these networks of follicular dendritic cells, and some smaller follicles with some onion layers of FDC and a decrease of blasts. We have to control this with the CD10 staining. Here again, onion layers, and here destroyed networks. These destroyed networks are mainly be found in lymphotropic virus infections, especially HHV8, but also in hepatitis C. Here, progressive change, germinal center. Okay, going back. We look for CD10. This is a surprise. So the reaction has worked. Granulocytes are positive, but here, more or less no, or only some follicular center cells, follicular center blasts, only a few on. And also the other germinal centers have decreased numbers of CD10 positive cells. Here the same, only single cells. This is a surprise here. Germinal center. Only some blasts are within. The number is totally decreased. These within the sinuses are mostly neutrophils. Okay, here again. Going back. What do we have? I think C10 is good. Kappa lambda shows a typical distribution, but possibly Ki67 would make sense. Here you see a normal germinal center with the layers of proliferating cells. And here, no proliferation, no strong proliferation within the germinal centers. Only here, a small one, but here not. Here also not. So it looks different. Here's a little bit proliferation. Here's more or less. Here's not normal, but because the layers are missing, but here is regressive change. So it's, of course, changed. We have to keep that in mind. So that was case number 2. You have seen these germinal centers with changed follicular networks, and then kappa for plasma cells, lambda for plasma cells. This is B-typical, and the strange proliferation in these regressive changed germinal centers. And in the end, taken together, the clinical symptoms, the clinical anamnesis, and the histological pattern, you can say these changings fit to multicentric Castleman's disease, HHV-8 negative. We proved that with immunohistochemistry, and it was negative. The patient was HIV positive and HHV-8 negative and hepatitis C positive. Okay. Questions can be written within the chat and will be answered later. Now we come to the next case, case number 3, a 22-year-old female. And this was a lymph node sampling from the left lateral triangle of the neck, suspected as Hodgkin's lymphoma. Clinical symptoms were undulating fever over several weeks, and large lymph nodes in multiple locations, weakness, and anemia. This is the first view here. You see some larger cells very soon, here and here. And you see some changed germinal centers here, diminished number of blasts, and we have to look at them. And here also, there's more or less no germinal center blasts. And here also not. And increased vessels here. So we should have a look first at CD20. This one. And you see in an overview many B follicles. Here again, and then these changed B follicles with diminished number of blasts. You can control this in CD23 at example. It's not the best one. And this is good. Again, we see some onion layers of FTC networks here also. and some regressive change germinal centers. No increased number of centroblasts. And here, B cells, some B cells intermingled in the interfollicular area. And then we should have a short look to CD30. And the CD30 here. Yes. Some smaller CD30 lymphatic cells. Yeah. Here. This is an increased number, and these are larger cells, sometimes surrounded by reactive T cells, like a halo. And here, double nucleated CD30 positive cells. So the question is whether this is a reactive lesion or whether this is partial infiltration of Hodgkin cells. CD30, CD15. Same area as you have seen before. And then you see Sternberg-Reed cell, Hodgkin cell, Reed-Sternberg cell, Hodgkin cell, Hodgkin cell. And some of these smaller blasts also show a combination of CD15 and CD30. So these are really Hodgkin and Reed-Sternberg cells. You can then find also in other areas. And the question is whether this is a Castleman's disease or a Hodgkin's disease. I think from the immunohistochemical seen from the histological presentation and the immune histochemical constellation, it seems to be clear that this is a Hodgkin's disease with regressively changed germinal centers. Okay, and then again, these cells, very convincing, CD20, they are negative, and these networks. And in the end, the diagnosis was classical Hodgkin lymphoma, maybe of nodular sclerosis type from other lymph node areas, but indeed not a Castleman's disease. But the germinal centers, please compare them with the other cases. They look sometimes similar. And you have first to find the large atypical cells. So I think, King, do we have time for
one more case?
One more case. Okay, I expect it. Okay, I will hurry up.
Make it fast.
Yeah, 66-year-old female with clinical indication hyperplasia of the tongue base, and clinical symptoms also fever over several weeks, enlarged lymph nodes in multiple locations, weakness and dysphagia. Dysphagia, I think, is driven by this hyperplasia of the tongue base. And then we will go into the slides. This is the overview. Larger germinal centers. And then here, diminished number of blasts. And this seems to be in a germinal center with some onion layers and thickened walls of vessels. And in the interfollicular area, an increased number of venules, high endothelial venules. Here again. At first, we look again for CD20. here, this one, or this one. Yeah. This is CD3, get your pardon. See an increased number of CD3 cells in the germinal centers, but a diminished number of blasts. That was CD3. And now CD20, this one. Larger numbers of B cells, larger B follicles, some a little bit changed, like this one and that one. You should have a short glimpse to the CD21 staining. And here we find this typical pattern of onion layers of the FTC cells. Here again, and here again. And it's always difficult to decide whether this is a reactive lesion with some patterns of Castleman's disease or whether this is Castleman's disease. In multicentric idiopathic Castleman's disease, it's very difficult to find a exact border. You cannot count the number of changed germinal centers. You must take together every information you can get of the patient. So in the end, this typical pattern you have seen before, FTC networks with these onion layers. This is BCL2. The germinal centers are negative. The survivors, Kappa lambda was also B typical or polytypical. And in the end, taken together, this is a typical example of multicentric Castleman's disease, but only with partial changing of the lymph node ground structure. So we are in the end, and I will come back to the faculty.
Okay, thank you very much, Professor Tiemann, for your interesting cases. At least nothing seems as it is.
Indeed.
We now have the questions, a few questions left, and I see one for Professor Toussaint about CD30 negative classical Hodgkin lymphoma. Do you believe in this entity or not? And as well as you, Marcus, do you guys believe in CD30 negative classical Hodgkin lymphoma?
I think it's not really an entity, but Thomas should answer first.
Well, the thing is, there is one or two cases that I made the diagnosis still, and that I interpreted it as a technical thing, but I would be very hesitant to make a diagnosis of Hodgkin without CD30.
I think it's the best idea to grab the telephone and then to request whether this patient has undergone a brentuximab vedotin therapy. I've seen twice cases of clear-cut Hodgkin's disease without a relapse, without CD30 expression. And then after brentuximab vedotin therapy, you can see CD30 negative Hodgkin cells.
Do you have that experience, Dan? Your pathologist reporting back CD30 negative?
I don't have experience. Also, not after brentuximab. No.
Okay. Okay. Very well. Then,
as this is reported many times in DLBCL after rituximab therapy,
yeah,
it's not. It's. I mean, it's possible.
It's theoretically it's possible. Certainly, it's possible.
I've seen it twice, and I was I felt lost the first time. I was like, this is not a question of technique, because the positive control was positive as usual, but the Hodgkin cells were indeed negative, but they had I think they had also PD-L1 and CD15, and that was in that case is the key.
Okay. Well, good to remember. Then Professor Toussaint has some remarks for Professor Dieriks.
Yeah, so the first part of the question is whether there are selection criteria for anti-PD-1 in classical Hodgkin lymphoma. In the trials, there has not been any obligation to report on the PD-L1. So it's assumed that all classical Hodgkin lymphomas have, due to their amplification of the 9p24.1, it's assumed that they have PD-L1 expression. So it's not required.
Yeah, but the point is PD-L1 is expressed.
Yeah.
But PD-1 is very rare. I mean, PD-1 positives are very rare in a majority of classical Hodgkin lymphomas. And so the question is, like in the New England paper, was it checked? Do you know whether they need a certain amount of PD-1 positive cells in order to have the anti-PD-1 therapy working?
I don't think in the trial it was checked, but there was another trial in which the group of Margareta Chip actually looked at responders versus non-responders, and what they basically see is that it seemed to, and it's in other groups, that it apparently the CD4 positive cells are important. They express PD-1, and it's also a bit comparable to the fact that the responders seem to have the Hodgkin-Sternberg cell seem to have expression of MHC class 2 on their surface. So it's the only thing we know. I think that probably the CD4 positive cells express PD-1 and are very important in the crosstalk between the Hodgkin-Sternberg cells, the macrophages and macrophages, more important than the CD8 probably. But it's still an open question, Thomas. I agree.
Well, then I still have a question for you, Dan, if I may. Is R-CHOP still the backbone of the therapy against non-Hodgkin lymphomas? Or is it in the era of the immune therapy? Do we have, as pathologists, have to consider other things?
Yeah, for diffuse large B-cell lymphoma, R-CHOP is still the backbone, but you can add the polatuzumab vedotin, so the antibody drug conjugate against CD79B is reimbursed in first line. For some very difficult to treat lymphomas like the gray zone lymphomas, the double, triple hit lymphomas, EPOCH, with the addition of etoposide to the CHOP is considered more standard. But we are at this point, I think the immune therapy is more in the second line or further. But I think we have the polatuzumab. It's the first time that an immune therapy in diffuse large B-cell lymphoma showed a better outcome when you combine it with R-CHOP. It's not monotherapy.
Okay.
So I think we are gradually shifting to first-line therapy, yeah.
Okay.
And in Hodgkin, the brentuximab already in the stage 4.
Stage 4, okay.
Yeah.
Very well. So do not render a diagnosis R-CHOPoma.
No.
Very well. Okay. Then to finish, I reserved especially 5 minutes for this, the discussion about Richter transformation. What is Richter transformation? Thomas, you have a clear view on this, only DLBCL. And Marcus, apparently a little bit more nuanced. Could you two explain the points of view for our audience?
Well, I think one of the questions was that if there are Reed-Sternberg-like cells present in a CLL, is this enough to call it Richter transformation or not? I think in this point, there are two things. Richter is, to me, a large cell transformation derived from CLL. But you can make a distinction between a clonally related large cell transformation and large cell transformation that is clonally unrelated. The cases that we studied are about half, but the majority of these cases are, I mean, Richter transformation can have several causes. It can be MYC-driven. If it's a MYC-driven large cell transformation, then it's very clear. But what we often see is EBV-driven transformations in which you have Rich-Sternberg-like cells. Some cases look very much like Hodgkin. So there has been reports of Hodgkin transformations in CLL. There is a nice paper discussing this in Blood Cancer Journal in 2022 by Rebecca King, discussing this topic on CLL with Rich-Sternberg cells versus Hodgkin transformation of CLL. But the cases we studied that had EBV-driven transformation, if you may say so, were patients treated with alemtuzumab of fludarabine and are in fact considered to be secondary EBV positive LPDs in the context of immune suppressive or immune modulatory therapy. And these cases are often clonally unrelated and are just a second, it's just a reactivation, clonal activation and reactivation of EBV in a patient with CLL. And semantically, I would not call this Richter transformation, but I would reserve the true Richter transformation as clonal evolution from a small cell lymphoma to a large cell lymphoma that is mainly MYC or P53 related. That's my opinion. That's my opinion on this.
Thank you very much.
This is old school, and I totally agree. This is what I learned during my career as young pathologist. But in the WHO, there is written Richter transformation is a transformation in large B-cell lymphoma or Hodgkin's lymphoma. This could be could have been a compromise, maybe a bad compromise, but this is written down in the WHO book. And that was our internal discussion. And I could not win the discussion because it was written there.
Okay.
That's of course the problem with the two running classifications. I was not involved in the.
We will not go in. We will not go into this discussion, if I might say so. The only thing is, when you are doubting whether you're dealing with a collision tumor, say like a follicular lymphoma or a CLL, and you see some big cells, when would you make the diagnosis it's a follicular lymphoma and Hodgkin lymphoma rather than follicular lymphoma with Hodgkin-like cells or CLL with Hodgkin-like cells?
I think it's depending on the immunophenotype. If you have a sure B-cell phenotype of these large blasts and with co-expression of CD30, for me, this is a transformation. But if you have, as in this case, a combination, it is normally a combination because the Hodgkin cells had been CD20 negative and had CD30 and CD15. So I think this is, of course, a collusion. Of course, they are derived from B cells, both of these clones, but I would not presume that this is really a clonal relation. So they are derived from each other. And for me, Richter transformation is always coming from one clone and then have different tribes. This is from the beginning 2 different tribes. I think that means you must not do intensive CLL therapy for a risky case, but you have to find out how to combine Hodgkin's and CLL therapy. That would be my recommendation in a tumor conference.
Okay.
What do you think about this, Dirk?
Do we have to? Well, first, I want to ask Thomas if he has. If you do also have to consider the microenvironment, the background inflammatory aspect of a Hodgkin when making a diagnosis of Hodgkin lymphoma.
Yeah, I think so. For me, I would never call a case of, a diffuse architectural disturbance with CLL everywhere and with scattered EBV positive or negative, but CD30 large cells, I would never call this a collision tumor. I would call this a CLL with HRS-like cells. I reserve the diagnosis of Hodgkin transformation, and I think I only saw a handful over the last 15 years. 2 cases that either have a second biopsy patient known with CLL develops Hodgkin in a later biopsy that is indistinguishable from the original. I mean, the first one is CLL, the second one is clearly Hodgkin lymphoma, and they are clonally related. I would call this a Hodgkin transformation, and all other cases I would, but that's a personal opinion. I would, because you often see HRS-like cells in CLL, in follicular lymphoma, if you look for them. And the problem a bit with CLL is that many of the CLL cases are by themselves dim in CD20, and these larger cells are dim in CD22, so they lack CD20, and you would call them true Reed-Sternberg cells based upon that criterion. I would not do that personally. But
Okay.
so I would reserve it if it's a true, I mean, true second malignancy, clearly separated from the CLL.
Okay. We are a little bit late over time, but I want to give Dan the last word on how to deal with this kind of discussion among pathologists in the clinical setting.
Yeah, I think we will first look at the aggressiveness of the tumor, of course, both clinical, biochemical, and yeah, PET scan can also guide a bit whether the uptake is higher in the transformed. But yeah, for a treatment, we will. If there is a discussion between the pathologists, we will see how aggressive it is to treat, I think. But it's always
the
very
pathologist?
interesting. It's always a very interesting discussion.
Well, that's a very diplomatic answer. And thank you very much for this. With that, I want to thank all the speakers, especially for their beautiful talks and also the lively discussion. I certainly have learned a lot. I want to also thank the technical assistance from Smart in Media in the person of Arno Schulz. I want to thank Recordati Rare Disease Group for sponsoring and organizing the meeting. And of course, I want to thank you all, the audience, wherever you are on this world, for your patience and to bear with us. I want to say that please fill out the survey, which will be sent to you shortly. And I want to say that the cases are available, for which you will get also a link. That's all I have to say. I would say take care and have a nice evening, and bye-bye to you all.